Ladies and gentlemen, thank you for giving an opportunity in this hall. My speech or spoke is primary debulking versus neoadjuvant chemotherapy. As you see in this slide, there is a little higher or near survival, and there are many prognostic factors here. The most important one, time of surgery and residual tumors, and also histotype. In our country, the incidence and mortality of ovarian cancer, 73 and 39 per 100 patients. These figures at the world, 6.6 and mortality less than 5 per 100,000. What about US? There is an epidemiologic trend as shown in this slide. There is decreasing trend, both incidence and mortality. Also increase the prevalence. In ovarian cancer, there is no effective screening program. So more than 60, 70 advanced stage ovarian cancer at the diagnosis. But there is a gene-based risk reduction surgery, aggressive cytoreduction with chemotherapy, with frontline therapy. But cure rate is very low after 5 years, 25 and 30%. This slide is very important. There are many histotypes, and each one is an independent pathology, because the origin, precursor lesions, and also the response to standard chemotherapy and the genetic alterations, and finally the therapy. As you see here, the first and high-grade serous tumor and PARP inhibitors, and also low-grade serous tumors, MEK inhibitors, and endometrioid type classified as high-grade or low-grade or P53 mutant group. And in this pathology, the immune checkpoint inhibitors and also mTOR inhibitors. And clear cell cancer, immune checkpoint inhibitors, tyrosine kinase inhibitor. So every pathology entity is different. Again, the response to standard chemotherapy is very high, high-grade serous tumor, and very low, low-grade serous tumors. So the response of chemotherapy and the very limited and low-grade clear cell and mucinous variant. The preparative workup for patient selection, primary debulking or interval debulking surgery. The first of all, take a history as a genetic origin, and lab study or markers. And imaging is very important for the parenchymal identification of parenchymal metastasis, liver, spleen, and lung. Finally, laparoscopic triage is very important for the identification of primary or metastatic tumors, and also resectability is feasible or not feasible. Then you will decide primary debulking surgery or interval debulking surgery. The therapy depends on patient's factors, age, performance status, and tumor factors, histology, grade, molecular, biomolecular markers, and genetic alteration is very important, and the clinical factors, accurate diagnosis, disease burden, extent of tumor, and experience team in high-volume hospital. This slide briefly. The first, check the genomic profile, then evaluate the extent of tumor, and also histotype, and the time of surgery is very important, primary or interval debulking surgery, and the aim, we will wait are 0, then otherwise the interval debulking surgery is better. After the diagnosis, there are 3 therapeutic modalities are shown in this slide. The first, primary debulking surgery, next, neoadjuvant interval debulking surgery, additional HIPEC, and also clinical trials. The first approach, platinum and taxane, and additional BEV in the GOG 218 and ICON 7. Also, those dense chemotherapy and IV, IP, and only IV chemotherapy. Then you will evaluate the genetic biomarkers, then you will decide the final therapy. And there is a change in the surgical approach. Over time, first of all, low abdominal debulking, then lower middle abdominal debulking, and then upper abdominal. Also now, extra-abdominal debulking, especially lung and the pleural cavity. As you will see here, and what's thoracic debulking cytoreduction. There are many progressing therapeutic agents of epithelial ovarian cancer. In the past, alkylating agents, then the platinum time, additional taxane, and the BEV, then finally PARP inhibitor and the checkpoint inhibitors. What about the R0 result? The first slide, hospital-based. Another one is Bristow meta-analysis. All of these showed the R0 is better than other variant in the US side. And also, European side, similar result. What about the small residual tumor? As you see here in this slide, R0 is better than other variant, PFS 24 months, and the overall survival 57. But 0.1, 0.5 centimeter in diameter, these figures very low. And also, optimal cytoreduction, the result very, very low than R0. Another important prognostic factors especially histotype. The wild endometrioid type is very high survival, then the next cycle is serous, and the clear cell, and also mucinous tumors. Mucinous tumors, as you know, infiltrative and expansive type. Expansive is better than infiltrative one. Is there any limitation of primary debulking surgery? Yes, according to metastatic size and dissemination of the tumors, especially small bowel, mesenteric implant, and also multi-segmental, multi-metastasis in the liver and the lung. Then we will start the neoadjuvant chemotherapy. What is the rationale of neoadjuvant chemotherapy? The first, reduce the tumor burden, increase total microscopic tumor clearance by lower multi-visceral resection rate. Another important point is reduce surgical morbidity and mortality, increase postoperative quality of life, lower stroma rates, less pain, adhesions, and reduce amount of healthcare resources required, operating time, ICU, hospital stay, transfusion rate, and also fluid shifts. And there are many prospective randomized study. The most important one for the not inferiority study, EORTC, and from UK, Cairo study. And then Scorpion study, superior study, and Japanese judge study, not confirmed Caro's and EORTC study. So, neoadjuvant chemotherapy is not inferior for PFS and overall survival from primary debulking surgery. What is the indications? Poor performance of surgery, comorbidities, advanced stage, low level albumin, and recent venous thromboemboli, and MI also stands. Another important one is chemosensitive histologic type. As you know, high-grade endometrioid, high-grade serous tumors are available for the neoadjuvant chemotherapy. Other histotypes, and there is a limited benefit. And also, finally, unresectable tumors. There are many retrospective studies. There is a different, as mentioned before, the Canadian study, all cancer and primary debulking surgery better than neoadjuvant one. Also, maximal debulking result, the same figures. Another important study as a retrospective and sheer database, the most and the R0 primary debulking and R0 interval debulking surgery, there is a different, again, primary debulking surgery result is better than neoadjuvant chemotherapy interval debulking. What about stage 4? And stage 4A and 4B. Again, if the complete cytoreduction within the abdominal cavity, the result similar. Neoadjuvant chemotherapy interval debulking surgery, short-term advantages, high cytoreduction rate, lower peri or postoperative morbidity and mortality, higher quality of life. And also there are many disadvantages. Primary resistant high-grade serous tumors about 15%, limited response standard regimen in low-grade serous cancer, clear cell and mucinous, and also endometrioid wild type. Problem of chemo-resistance clones. Resistance-related recurrences also higher cytoreductive surgery rate in interval debulking surgery. We will wait the high-grade serous tumor after the interval debulking surgery, better survival, but the similar one. What's the trend of treatment modalities? And as you see here, there is a decreasing trend, primary debulking surgery, and increasing trend, neoadjuvant and interval debulking surgery. Another important slide for you, there is increased neoadjuvant chemotherapy and interval debulking may be very simple approach, in my opinion. Is there any opportunity for HIPEC in interval debulking surgery? Yes. There are 3 important studies. The first one from Netherlands, another one from Korea, South Korea. This is the Netherlands results. My friends will give you in detail. For that reason, I want to say something. Another South Korean study, interval debulking, and as a second point, limited benefit. CPOR, another prospective randomized study, there is a beneficial effect of neoadjuvant plus HIPEC. This is our study in the recurrence, platinum-sensitive recurrent disease, and also if the first recurrence is very suitable for HIPEC. What about cost? And cumulative lifetime cost in neoadjuvant group is higher than primary debulking groups. And neoadjuvant cost-effective only high-risk subgroup, especially stage 4 tumors, older age, poor performance status. And then all targeted therapies based on molecular profiling and biomarkers and individualization. In conclusion, ovarian cancer remains as the most lethal GYN cancer, no effective screening program, more than 60 advanced stage, currently primary debulking surgery with no residual tumor plus adjuvant chemotherapy is standard of care, neoadjuvant interval debulking in selected cases, and the final platinum resistance after neoadjuvant is debatable. We will wait the result of TRUST study. Thank you very much.